Shakira and IONM4LIFE, a senior neurophysiologist and creator of Wisdom Wednesday, bringing you the second episode on IONM4LIFE Adventures in Neuromonitoring podcast and YouTube now. Last week, we spoke about the brain. This week, we'll be speaking about the heart and cardiac neuromonitoring. I know many locations still don't monitor these cases yet or aren't even aware that you can monitor them. So let's dive in and start with the anatomy of the heart. The anatomy of heart is a critical component to understand to ensure that you are optimally monitoring the structures at risk. So as you can see, the aorta is in the shape of a cane. So you start at the aortic root down at the bottom, you go into the ascending thoracic aorta, the great vessels that are located within the arch, and then down into the descending thoracic aorta. That supplies all of the areas that are critical to the body's survival, basically. The great vessels are the innominate, the common carotids, and the subclavians, and these supply the critical areas of the arms and the brain. So then as you work your way down the cane, you're going from the handle of the arch down into the bottom portion, and that's the elongated portion. That's your descending thoracic aorta. So in your descending thoracic aorta, you have all of these critical components that are supplying your spinal cord. So the posterior spinal arteries, the anterior spinal arteries, the perforating and segmental arteries, along with the artery of Adam Keinowitz, then leading down into the mesenteric and iliac arteries. As you can see, a lot of important structures and their blood supplies have a possibility of being disrupted. So when we're talking about cardiac neuromonitoring, what we mean is, let's talk about an example of what we would be doing. So say there's an ascending aortic aneurysm, and we're going to be monitoring that. What's the best way to do that? The best way to do that would be with ulnar SSEPs and a full headset to make sure all of the lobes of the brain are captured with EEG. So this will allow us to monitor the upper extremities and the brain. Why would we do that during an ascending thoracic aortic aneurysm? So if you look at the anatomy of what I just showed you before, in between any of those portions, the clamp can be placed proximally and distally so that the aneurysmal pouch could be removed and replaced with a graft. So when those clamps are on, if the clamps are above or below any of those eloquent structures, such as the subclavian or the common carotid, you might not have adequate perfusion. At that point, you would see a decline in your ulnars or maybe a flattening of your EEG, and then you would be able to alert the surgeon and perfuse for a moment and then reclamp while he does the procedure, or make some adjustments so that the procedure could be as safe as possible. So when the clamps are on, we're going to deem this a critical portion in the procedure for those reasons, because things can hyperperfuse. If we go back to the heart image, you'll see where the clamp is placed. You can be in the brachiocephalic trunk, the common carotids, the subclavian arteries, and all of those things would allow you to know, is the brain more at risk? Is the arm more at risk? So then you can kind of keep an eye on which ulnar SSEP or EEG you should be looking at. While you should be looking at both of them, sometimes you just want to shift your eye to a more important location when you know that it's more at risk. So now let's think about the descending aortic aneurysm and how we would monitor that, since we just talked about monitoring an ascending aortic aneurysm with ulnar SSEPs and EEG. As we learned earlier, this descending thoracic aorta perfuses the spinal cord primarily. Therefore, in addition to monitoring the EEG and SSEPs of the ulnars, you want to also incorporate the motor evoked potentials and the posterior tibial somatosensory evoked potentials. This is because you want to make sure that the front of the spinal cord and the back of the spinal cord are adequately monitored for any possible ischemic events. Again, as you see, the location of these procedures makes all of the difference. So whether it's the root, whether it's ascending arch or whether it's descending, you're monitoring different things and cueing your mind to what is the most at risk. They will also do other things during heart procedures to help eliminate not eliminate, but lower the likelihood of having your spinal cord not perfused properly. So what they'll also do during these procedures is they might put in a CSF drain so that you can drain off CSF if they think that there could be a spinal cord injury. This will allow the spinal cord to decompress and have more space. So that's one of the things that they'll do. You can also, and they usually like the blood pressure to be up during the procedure so that the cord is perfused after they put the stent grafts in. So there's a lot of little things that you can do to keep the spinal cord safe. But with the addition of motor evoked potentials and posterior tibial somatosensory evoked potentials, that gives you a very high sensitivity and specificity of the spinal cord's safety during the procedure. Let's switch gears a little bit and talk about blood flow and the different stroke types. The coronary arteries are located near the root of the aorta and supply the heart with blood. The heart then sends the blood through the aortic valve to your aorta and through the rest of your body. With this flow of blood supplying your whole body, the risk of stroke becomes apparent, right? So if you're pumping something in and everything else could pump out and go everywhere else, this is primarily how plaques get thrown and things get blocked or disrupted. So that makes it very easy to understand that during heart surgery, your stroke risk is higher than maybe during other procedures because you're moving so many things around that have a lot of plaque, vegetation, a lot of fat built up, and those things could get easily knocked off and disrupt blood flow, and you don't know where they're going to travel to because your heart pumps everywhere. For this reason, the consideration for stroke and stroke types become absolutely evident. You're pumping blood, you could be throwing something somewhere. Strokes are generally caused by a blood clot that comes from somewhere else that then travels through the bloodstream to the brain and could block it and cause an issue, which is why they usually like EEG monitoring during these procedures, because they're very aware, and by they, I mean the cardiothoracic surgeons, that a plaque could be dislodged in the heart and thrown somewhere else. So that's why the brain is a very important structure to protect in various different ways and to prevent from having a stroke. So what are the stroke types? The stroke types are an ischemic event, which is a blockage in a vessel leading to the brain, a TIA or a transient attack, which means that you had a blockage for a period of time and then it went away. So it was only a momentary blockage and then it went somewhere else. It was too small to cause a problem. So it was just a disruption. And then there's hemorrhagic, that's the bursting of a vessel in the brain causing bleeding in the brain or either around it. So then lastly, the most important one, and I have seen this before, a lacunar stroke can occur. And this is the deep portions of the brain that can become disrupted due to not an embolic stroke that travels, but because of a lack of oxygenation to that portion or hypoperfusion. And this can be basal ganglia, pons, thalamus, those deep important structures that coordinate the activities of your body. So if you're lacking oxygen to these important areas, you're not going to be able to move, and your movement is controlled by your motor evoked potentials, corticospinal tract. So that's why motor evoked potentials are very important to capture these type of deep strokes that might be missed by SSEPs or EEG alone. So since the motor evoked potentials can capture these deep structures of the brain, the addition of them during descending thoracic aortic procedures is very important. And I would argue that during any heart procedure, they're important because you never know where the plaque can travel, where it might lodge, where it might disrupt or prevent blood flow to eloquent areas. So in a perfect world, you would be able to monitor all your heart procedures with MEPs, SSEPs, and EEG to make sure that the patient is totally safe. Is this likely? Absolutely not. Why? Because your cardiothoracic surgeon is going to do a sternotomy. Does he want any chance of movement during a sternotomy? Absolutely not. So you're going to be paralyzed during like almost the entire surgery. So paralytic's going to be on. So how do you still try to squeeze some MEP in? So you have a conversation before and say, hey, I want to get some baselines before you make incision. You could paralyze during the whole procedure. I'll have my baselines to start and say, this is how we started. And when you're about to close the procedure, reverse the paralytic. Let me do another set of motors so I can say this is that your motors are the same as at the start or that something changed and an intervention is required. So this will allow us to optimize the patient post-operatively. Because remember, the goal is to optimize the patient's outcomes, and that's only possible with optimal monitoring regimes, knowledge, and information. And you have to convey this properly to the surgeon so that he understands, because the neurosurgeons and cardiothoracic surgeons are very, very different, right? Neurosurgeons are in tune with neuromonitoring most of the time, and cardiothoracic surgeons are more in tune with keeping the patient alive than understanding the full depth and breadth of neuromonitoring. So they take a little bit more education. So be open to teaching them. They like to learn and they want to protect their patients and they want to keep their stroke rates down. So that's how you can start those conversations is say, hey, I have a way to optimize and lower your stroke rates. Let's have a conversation. I would say that the most frequently monitored cardiac procedures are TVARs, cabbages, ascending aortic aneurysms, and bypass cases. These cases are monitored primarily for 3 reasons. You want to capture any ischemic event that could occur. You want to let the surgeon know when the patient's adequately cooled so that they're neuroprotected properly, and that means suppressed EEG and SSEPs. And you want to make sure that those signals come back symmetrically post-cooling and rewarming if you're on bypass. So monitoring during cardiac procedures allows cardiothoracic surgeons to optimize the postoperative care of the patients. Patients can go to PACU and not be assessed for hours, or they could be loaded up on propofol and not get assessed until the next day. So if they had a stroke during surgery and neuromonitoring wasn't there, nobody would know, maybe for 24, 36 hours. That's a problem. And that is a real thing that happens often. So if we are able to be there, neuromonitoring, and able to inform the surgeon that something happened, that a stroke was there, we could possibly identify what type of stroke, depending on how the change would evolve in our signals. This would make a huge impact on the patient's recovery. With neuromonitoring present, a stroke can be detected sooner. The patient could be managed properly and optimally with the right scans and treatment and physical therapy in order to have the patient recover faster and give them a better quality of life. So now that we know why to monitor these procedures, let's think about what happens if we have an alert, right? How do we convey this information to these surgeons that don't really know what neuromonitoring does? So let's say you have an alert and the cardiothoracic surgeon could act like one of the neurosurgeons and say, I didn't do anything, must be technical. We all have heard that at least once or twice, right? So it's pretty easy to differentiate technical versus real changes after a period of time. So let me walk you through my questions that I ask myself. First thing I do, how are my connections? Did anything come loose? Are my cables faulty? Did an electrode come out? Did any of my motor leads dislodge? Did anything change? Did anesthesia change drastically? Did they bolus? Was there pressure changes? Any of those types of things. Second, is the table turned? Could the surgeon be leaning on the patient? Are the legs flex? Did the leg fall off the bed? Are the arms still secure on the arm board? Again, depending on the changes you've seen, you want to check everything from head to toe. So that's what I do. I start at the head and I move down. Do I need to adjust settings on my system? Do I have to change the voltage, change the duration, change the train? Is anesthesia deeper than they were when I started that I need to change my rate? Or can I improve my signals somehow by just changing something in my settings instead of going up and manipulating the patient during a key part of the surgery? And then you ask yourself, does it make sense? Like, does this alert really make sense with what's going on? Knowing the procedure and knowing how you can correlate it is extremely crucial, which is why I try to walk people through not only the surgical steps, but the anatomical steps so that you know exactly where you are in the procedure and if that makes sense. If you have a random arbitrary change during your procedure, say like your foot randomly went out for no reason, but everything else is okay. Do you think that that would be a real change? Maybe, but more likely it could be a lot of anesthesia on board that's not allowing that signal to get all the way distally because some of the cortical synapses are blocked up. So thinking through those things really helps your brain to just flip gears and be like, okay, let's go to the next step. Know the anatomy, the procedure, the MRI, if knowing all of the things of what you could expect and what you should expect and what anything in between could occur. Having all of this information is so important. So that's why you look at the MRI. You know the patient information, you know their background, you've looked at the chart. All of these things allow you to put the puzzle together really easily. So if after checking through all of those things and the alert is still present, then it's probably a real event, right? At the end of the day, the most important thing that you can learn is to trust your data. As new clinicians, I think that's the hardest thing to learn because a lot of them will say it's not real. Do you know what that means if you're saying it's not real, or do you just not know how to fix it not being real? So if you don't trust your data, what can you trust? Because at the end of the day, that's exactly what you're doing is you are a piece of the puzzle, walking things through and putting it together to make sure that it makes sense if there is a real change versus not real, right? So if you don't trust what you see, who will? And the surgeon won't. So make sure when you're conveying your information about the change, you are concise, you are confident, and you are clear, because those 3 C's make a huge difference with the surgeon trusting you and your level of confidence in what you're seeing as well. So now that you know all the benefits of neuromonitoring during cardiac procedures, comment stimulating down in the comment box below if you found this information useful and if you will now try to add a cardiac surgeon to your target list. So we hope that you will let us know if you want to see anything in the future, if you want to learn anything in the future, if there's a modality, a procedure, an anatomical topic, variant, something that you want to know about, please let me know at shacktas@gmail.com or message me directly on LinkedIn. I'm always happy to answer any questions. This is IONM for Life. Have a stimulating week, my friends. See you in the next one.